program very soon. So in this background, we could have no better person here to speak upon it and answer any questions. I hand over to Dr. Mukund Penurkar to introduce our dignified guest.
Thank you very much, Pushkar. I think we will start on time, and it is my pleasure to introduce Dr. Raman Gangakhedkar. Dr. Gangakhedkar is presently Dr. C G Pandit National Chair for ICMR New Delhi. He has been former head division of epidemiology and communicable diseases, Indian Council of Medical Research, New Delhi, and Director in Charge, National AIDS Research Institute, Pune. Many of us know Nari very well. He has been working in the field of HIV for over 3 decades, and he is expert in the HIV medicine and associated infectious diseases, epidemiology, and public health. He was one of the key players in advocacy since 1989 and have been involved in policy making at national level on infections, prevention of mother to child transmission, and STI management, in addition to other key population specific policies. He has been a member of many prestigious international committees on different facets of HIV disease, including those constituted by ACTG, WHO, UNICEF, UNFPA, and UNAIDS. As a clinical research group and epidemiology and operational research group on COVID-19. He is a member of scientific advisory board of ICMR. Institute of body of the new aims constituted by the Ministry of Health and Family Welfare, Government of India. He has been a member of Empowered Group 2 on COVID-19. I think, and he has over 200 publications to his credit and has published 5 books on HIV infection. I think without losing much time, we will hand over the mic to Dr. Raman Gangakhedkar. He has been recently awarded Padmashree in 2020. Over to you, Gangakhedkar, sir.
एकच सेकंद ना, ते थोडं स्टिकी दिसतंय.
Yes, sir. No problem.
काय प्रॉब्लेम काय झाला?
सरांनी थोडासा वेळ ठेवला म्हणून सांगतो. I had my primary education at taluka level known Gangakhed, and his surname is Gangakhedkar.
Yes, sir. Your screen is visible.
नाही पण ते फक्त ह्याला थोडं त्रास देते. आपण एनलार्ज करायला ते.
If you enlarge it, it may not move. If you keep it small, it will.
Yeah. It is full screen now.
Yeah. Sir, thank you for this particular opportunity. I know it's a little difficult task. In the first place, I am speaking with technical issues that are associated with this particular vaccine. And also, I have to ensure that we tend to look at certain operational or common questions which patients are likely to ask to us. I would try to do justice as much as possible. But at the same time, since we have a question answer session as a follow-up, you could ask whatever question you want to. So we look at COVID vaccines and try and understand that. Now, why do we need a vaccine against COVID-19? We know currently within a year's time, 9 crore individuals across the world have acquired this infection. Over 1 crore have occurred in India. You also find that there are certain countries which are facing second and third wave of this infection, and the numbers are enormous. When you look at USA, they went close to about 3 lakh per day. Now that's a horrible number to even imagine, despite the fact their population size is far smaller compared to India. Even in England, with such a small population size, you have figures that have been achieved as about 60,000 per day. And there is lack of availability of beds, which is making a major issue with respect to handling this outbreak at this juncture. What is also important for us to recognize that this infection is not only fatal, but we are trying to understand the disease biology, and more we are recognizing one issue, that it tends to bring in certain other morbidities even if you recover with this particular infection, and they can affect our quality of life. But the scientists have successfully developed vaccine only in this 12 months period, which is a dramatic thing to happen, but this has happened. So why should we not use this opportunity? If you look at what is happening today in JHU trackers, graph that we by and large see, the green line today belongs to USA. But you look at the second peak that tends to occur there, that is actually of India. And you start realizing that in USA, they are facing third wave. Perhaps people in the European countries, they are facing the second wave to a larger extent. And we are just completing our first wave. So essentially, our position in terms of, or our level of outbreak is slightly different as of now. We are just completing the first phase. The next wave, as other countries are witnessing, if you try to see little closely, in UK, you find that the rapidity of rise is extremely high than the first increase that has happened. It's not only in UK, but you also see it in South Africa, which is a major cause of concern, which means if other countries also start getting second wave, perhaps it should not be a surprise to us if the wave can be rising as rapidly as is being seen elsewhere. Now you look at the US hospitalization data, you find that in first wave and second wave, they were almost equal. They had only about 60,000 odd patients getting admitted even at the peak of infection. But today that number is more than 2 times higher. Now, which essentially speaks of the gravity of the situation if we were to provide healthcare services to people. Now, what is our advantage? Our advantage is first wave is on a decline. The second national sero survey, which was undertaken in September, that had revealed that the seroprevalence of antibodies was close to about 6.6%. That is the overall seroprevalence that we had seen across the country. There are people who doubt that, but we don't worry about that part solely because it was a very nicely designed sample survey, which was perhaps representative of the country far more better. We use NFHS like frame in the whole thing. The third one is just completed very recently. Now, even if I assume the data is being analyzed, the lab testing is continuing to go at this juncture, even if we assume that there may not be tenfold increase between two sero surveys as it had occurred earlier, but even if it is 3 or 3.5 times higher, you might only reach a figure of 22 to 23% population being actually protected by way of had already acquired infection, maybe having temporary protection against this particular infection. But what does it point to you? The vulnerability continues to exist in a larger population, and the timing is on our side, which is one of the silver lining that we have. Now, if you look at the key determinants of the number of new cases, things are changing very rapidly. Earlier, it used to be that number of infected transmitters as seeds, which tend to be planted in different geographic areas, they used to determine the size of new infections that tend to occur. Population density and ventilation was another deciding factor which could actually impact the development of newer infections. The size of usual social network that an individual had, the mobility that one used to have, because the risk of exposure through droplet infection also increases rapidly when it comes to mobility. Proportion of people following COVID appropriate behavior, which used to be very high in India compared to rest of the countries based on IHME data. But of late, what we are seeing is there is a decline because of COVID fatigue that is setting in. And everything used to revolve around super spreading events. No, if super spreading events occur commonly, the numbers used to increase dramatically. However, now super spreading viral variants are also being found out. Now that's something which poses another challenge. It's not only human behavior, but the viral transmission efficiency is going to determine what number of cases could actually come. Now, what is the evidence today? If you look at the impact of rapidly spreading variant, you realize that every month in UK, they were testing these samples which were coming to them for UK variants as well. Now, if you actually look at that, the proportion tends to keep on increasing, and the proportions of cases that were arising due to variants has suddenly started increasing at a dramatic pace in UK. So, which essentially means the number will be determined by a super spreader virus if it acquires a mutation which can be spreading rapidly into the community. The most important thing which we have to understand when it comes to mutations, did we ever expect, at least I can confess here, I never expected that mutations will be as common. All of us know that the rate of mutation per month, as it was estimated earlier, is perhaps 4 times lesser for HIV, 2 times lesser than influenza. But then it surprised us. No, one reason why I used to think that perhaps this will not happen is there are two factors which are part of the epidemiology or transmission dynamics. One is short duration of survival of SARS-CoV-2 once it enters into the body. And that's the reason, if you recall, no, we said 10 days after development of symptoms, you don't need to worry whether the virus is alive or dead. No, because the survival was lower even within the body. And there is non-availability of specific antiviral because you could have a selection pressure that could come from an antiviral drug that you are using. But the defined development of variants perhaps is an indication of immune pressure that is mounted by the body due to repeated use of convalescent plasma or effective use of monoclonal antibodies. Unfortunately or fortunately for us, we don't have that pressure. Neither UK had that pressure. Neither South Africa had that pressure because Eli Lilly and Regeneron monoclonal antibodies were not there. It was only in USA. So that immune pressure is perhaps exerted by repeated use of convalescent plasma. But second thing which is also important is there could be a small number of immunocompromised individuals who may fall in that classical category which we say is about immunocompromised hosts, but they are likely to provide longer survival once the virus enters into their body. We do not know how far this will turn out true, whether it will be impacting our own outbreak as well in India is something which needs to be watched very carefully. Vaccinating those who have repeated exposure and immunocompromised individual holds the key to reducing development of new variants. So there is another facet that we all healthcare workers have to remember, frontline workers have to remember, that if those who are going to get repeated exposure, perhaps if they are vaccinated, the likelihood of that immune pressure being exerted by different individuals over the virus and virus trying to win the war by producing a variant will be reduced to a larger extent. What if we don't reach herd immunity quickly? If you look at a recent paper that has been published, if you look at the scenario that he has developed over it, this is a modeling that they have done, looking at the data that tends to emerge from other human coronaviruses as well. Generally, human coronaviruses transmission dynamics suggest that there are two types of immunities, infection blocking immunity and disease reducing immunity. But the infection blocking immunity tends to wane rapidly, and the disease reducing immunity is long lived. And the result is, when you have such a combination, you will find that strain variation and mutant escapes are likely to become more commoner. The disease that is likely to become benign over a period, but then it is more likely to become endemic. And that's another worry that we will have to keep at the back of mind. The reinfections may increase, and like what is being described, though I don't think we have sufficient evidence to say that in UK infections are occurring more among children, but that is a general trend you might see over a period of time, that when the disease becomes endemic, perhaps you will find that children becoming infected and being transmitters and also developing disease will be an important issue. We must all remember that when children are likely to get infection with such a dreaded virus which produces a multisystemic disease, the long-term implications on the health of the child is likely to be difficult to be gauged at this juncture. But we should be worried, how do we protect our children for not and ensure that endemic disease does not occur here. The implication of development of rapid transmitted variants, if we try to consider that part, earlier when we used to think about herd immunity, different countries tended to use the data for modeling and they came up with different figures. But generally for herd immunity is a concept which is loosely being used today. No, most often when you hear herd immunity, people tend to connote the immunity that tends to come from natural infection that can occur. But herd immunity constitutes both the natural infection as well as the immunity that tends to come from the vaccine that you provide. The risk, the level that we wanted to achieve tended to vary by different calculations. It used to lie between 58 to 74%. Now, if you look at the current new predominant variants, which are more transmissible, though they continue to be amenable to vaccines, there is one issue that we must keep at the back of mind. There are no more mutations in spike protein. Now, if you add more mutations in spike protein, perhaps escape mutants are likely to come up more often, and therefore the newer targets for herd immunity will require two things to happen. One, rapid scale up of coverage, or herd immunity would perhaps go towards 90% or more as one of the factors if we are to control this outbreak. One of the things which India was very successful in was lockdown, and we could ensure that our outbreak or serious onset of this particular epidemic started 4.5 to 5 months later. But if you try to use this lockdown now, no, in an established outbreak, if you look at the data, you will realize that these countries tend to have all kinds of issues with respect to even if they had lockdown, there is a dramatic rise in infections that is being seen even after 2 weeks period. Now that's something which is very worrisome, and we need to be cautious. We need to understand that the one of the tools as lockdown is not a possibility today to be used. The speed with which some of the countries, recognizing all these factors, are providing vaccine is something which is something to be looked at and perhaps thought over by us what we should be doing. If you look at the efforts that people are making, there is a rising trend, and this rising trend, if you look by smaller countries, you will find a country like Israel already has immunized 22% people. We understand that the population size is very small. You look at UAE, their population size is very small. But unless you make that effort, we are not going to be successful. And the effort cannot be only governmental efforts. It has to come even from people's acceptance of these vaccines that are being likely to be provided. If you want to have a high level of immunity using herd immunity, using vaccines, the rate limiting steps need to be understood. One is global and national population size, which is too large in order to provide the vaccine. and limited vaccine production capacity, especially because there are certain platforms from which the vaccines may come. Their scaling up of production is likely to be difficult to be made in a short period of time. We won't go into those details as of now. And if that is an issue, one calculation which I had made some time back, they tended to think that in this particular scenario, we would require about 5 years' time to vaccinate everybody, no, globally. Now, that's something which is really a challenge for all of us. How do we compress those timelines? Only then, perhaps, we will have some kind of safety, not only from fears, but the risk of being one who is vulnerable. Looking at the broader objective of vaccine rollout, there are two major objectives. One is reduction in mortality and reduction in transmissions that could occur. Now, one needs to understand that looking at the limited availability of vaccine supplies, groups have been prioritized. That's the only way we can move ahead and ensure that at least the efforts will have to be done in prioritized manner, in a phased manner at this juncture. Who are those who fall in our priority groups? They are healthcare workers, frontline workers, persons above 50 years of age, and those with comorbidity. Their total number is estimated to be close to about 30 crore. The list of first two groups is available with the states. So the app that you would have would always be pre-populated, and therefore perhaps we will be able to use that particular information to provide vaccines in at least the first two risk categories that we have defined. Why healthcare workers are important? You find that if you actually look at healthcare professionals, the risk of acquiring this infection is almost 8 times higher compared to the other lower risk category individuals, including frontline workers. Now, despite the fact that we use PPEs, the risk of acquiring... Hello?
Gangakhedkar.
Hello? Hello? Am I
Sir, please
audible?
yes, sir. Please continue. There was an unmuting from a member. Sorry.
Okay. So one of the things which we have to recognize that healthcare workers, despite using PPEs, continue to have far higher risk than what we imagine of acquiring COVID-19, which could be prevented by perhaps adding one more weapon to the armamentarium as vaccine. The older individuals and with chronic morbidities are also prioritized, essentially to reduce the number of deaths. Now, if you want to understand these vaccines little more, we will try to go over that part. How does this AstraZeneca vaccine, which is available here, how does it work? The genes of spike protein have been inserted into the adenovirus DNA, right? Now, when you insert those genes, this adenovirus will go inside the body and it will enter into our cells, and where once it enters into the cell, it will inject its DNA into the nucleus. But there is one thing which we must remember. There is no integration of this injected DNA with the host DNA. It will go into the nucleus, and there it will produce mRNAs. mRNAs are the ones which will be responsible to carry the message carry the message as to how spike protein has to be produced. And this mRNA will provide this information, and spike protein will be produced in the body. Now, once spike protein is produced, you will find that our immune system will recognize it using our antigen presenting cells. And these antigen presenting cells will also ensure that there is a sensitization that will occur of T lymphocytes, so that you would have a sustained memory of this infection that has come inside our body. Now, if you look at Covaxin, this is based on a traditional platform. You can easily describe it as whole inactivated virions. Now, these kinds of vaccines, we have used it in the past. One of the things is, this being a whole inactivated virion, you must realize that it can generate antibody response not only against spike protein, but others as well. And Covaxin has reported to have lesser adverse events, less than 7% adverse event after 3 months of vaccination as such. Now, the entire new platform race that has come in, new and newer innovations are coming. As all of us know, that we have to provide this vaccine 28 days apart, the ones that will be available in India. Now, if that is the case, one worry would be, can I provide one dose vaccine? Perhaps that dream could also be possible soon, and it may also be possible even in India, because there, if you look at the conventional RNA vaccines, which are two-dose vaccines, what they have done is it's a non-replicating mRNA that is given through the vaccine. However, you could make this vaccine in a different way. If you add replicate genes, there would be a self-amplifying RNA vaccine, which will reduce the amount of mRNA that you have to put, and also ensure that only one dose could be a sufficient dose, because your loading dosages are going to remain small, and you could ensure that there would be persistent exposure for about 2 to 3 weeks time in the body by this replicating mRNA. Now, this vaccine, interestingly, is also being tried to be developed in India by Genova and MCure Pharma. Now, they are trying to do their best. They have already asked for phase 1 and phase 2 studies approval by the government, which has already been given. So we need to look forward to a newer method that might come, which may also reduce or increase our ability to provide vaccines in a short period of time to such a large number, because these could be one-dose vaccines. Is there any advantage? Apart from that, there is another one, which is J&J vaccine, which is the only other vaccine which is one-dose vaccine, but the phase 3 trial is ongoing as of now. It could complete any time in US, and we will know the results as well. Is there any advantage in routes of administration of vaccines? Traditionally, we know we provide it through injections, but there is a handicap there. We don't have a clear data which tends to tell us whether there will be a production of IgA, which is really important to ensure that the vaccine will protect even from infection, asymptomatic or mild infection that tends to occur. It is possible that even the current vaccines may be doing that, but one doesn't have that kind of an idea because of the trial designs and the short time that we had to measure everything. But if you look at oral dosages, we know about polio. When you think of nasal vaccine, there is very little data that is currently available. But Bharat Biotech has a collaboration with a European firm, and they are also planning to launch a nasal vaccine, which will essentially produce even IgA so that that infection can be prevented. And phase 1 and 2 trials have also been, the request for the same has been submitted to DCGI. So there are a whole lot of things that are happening in the vaccines against COVID-19 platform. If you actually look at the current status of vaccines globally, you find close to about 67 vaccines are currently in human trial phase. And if you look at those in preclinical phases, development also, you find their number is about 224, which to my mind is a big silver line, mainly because if anything comes, these manufacturers will be able to maneuver themselves so well that they could do it early and move into trial phase very quickly if there are variants which would perhaps show some kind of antigen shift, and then move ahead with vaccine production. Because generally with these vaccine platforms should not require more than 3 to 4 weeks of work to produce a newer vaccine altogether to be tried among animals and human beings. Which are the vaccines that have been approved so far? We know that Pfizer and Moderna have been approved in USA and UK. USA has also additionally approved AstraZeneca vaccine. UK has additionally approved AstraZeneca. The AstraZeneca phase 3 trials are going on in USA. China and Saudi Arabia, they are using Sinopharm vaccine. You have Russia, which is using Sputnik V vaccine. And in India, you have Covishield and Covaxin. These two vaccines have been approved. The news that newer vaccines are not only developed but are being provided to people for vaccination can generate two things. One is vaccine eagerness, the second is vaccine hesitancy. Both tend to depend on two essential factors. One is risk perception and understanding the efficacy and adverse event profiles of each of the vaccine. Whatever may happen, whether it is eagerness or hesitancy, both are going to pose challenges, because that will see what kind of hurdles are we likely to face in providing vaccines to people. Now, one survey, the first survey that was done by Wall Street Journal. This was done in December 2020, where they tried to find out what proportion of people across the world have vaccine hesitancy. But I have picked up only one slide out of those three which are important. And they tend to tell you that people are either worried about side effects, so they don't want to take the vaccine, too fast a vaccine trial, they perhaps may not be as effective, I may not get COVID, and perhaps there are some who are anti-vaccines altogether. And therefore, these issues have to be really handled well if we are to move ahead towards scaling up. Now, where are we with respect to the early interim results of the vaccines that have generated data so far until 2021 till today? Now, if you look at Pfizer and Moderna are mRNA-based vaccines. They are put into the mRNAs have been put into lipid nanoparticles, and this original technology, it is said that it belonged to Moderna. Moderna was a pathbreaker in the whole field, but Pfizer moved ahead very quickly, and you realize that they have shown an efficacy of 95.5%. Almost both of them are close to 90%. They have some temperature issues, but none of these trials were conducted with Indian participants in the study, and naturally they will have to conduct a bridging trial if at all, if they have to be provided in India. When you look at AstraZeneca vaccine, the adenovirus in which the gene encoding spike protein has been put in. Now, this adenovirus has been brought from chimpanzee, the stools of chimpanzee. And why this has been done? Because adenovirus infection can cause common cold, and it's fairly common infection even among people. Now, if we provide some adenovirus which had already infected a human being, you will find that it will not be able to immunize the person properly, only because there would be antibodies which will be brought into action immediately by our own body, and it will not allow this virus to do its own work. Now, there, as in AstraZeneca, there was an issue, which is an error, or whether it was by design. No, there are two efficacies that come. One is 90% efficacy that has been reported, where the first dose was a small dose and the second dose was a standard dose which they have provided. And when this was compared with those in participants where there were two standard dosages that were given, with standard dosages, the efficacy levels, they tended to come down. But one of the advantages of AstraZeneca vaccine is it can be stored. The remaining 4 vaccines that we are going to see, they can be stored in normal temperatures to which we are used to in vaccination program. 3 of the vaccines, AstraZeneca, Sputnik, and Bharat Biotech's Covaxin, you have Indian participants. The trials are being conducted in India in 2 instances of AstraZeneca and Sputnik V. Now, if you were to compare the AstraZeneca and Sputnik V, you will find Sputnik V is also an adenovirus vaccine, vector vaccine, and then it has a spike protein gene, just as AstraZeneca has. But there is a small difference. In the adenovirus that has been used in Sputnik V, there is a clever trick that has been played. In the first dose of the vaccine, you tend to use adenovirus vector as adenovirus 26, which rarely infects human being. And then In the second phase, second injection that you give after as a second dose, you find that they are using adenovirus 5. And so therefore, logically they are fairly also strong, that if I provide one kind of a virus, I am also likely to see there would be a reaction from my body. My body may produce antibodies, and therefore they changed cleverly the other virus that has been used as for as a vector, and so you have adenovirus 26 plus adenovirus 5. They are used in Sputnik. Now, when you look at their claimed efficacy, it's 95%. Now, that's something which we have to understand at a backdrop, that they have only observed 31 infections in the interim analysis as one of their, what would I say, sample size, the way it has been calculated, only 39 infections have been observed. Now, one good thing that has happened is they are also planning, AstraZeneca and Sputnik V are also planning to have a trial for interchangeability. So, because both of them are based on adenovirus vector, both of them use the spike protein gene. If you alternate, perhaps first dose being given of, let's say, Sputnik V, and then second one coming from AstraZeneca, how does it impact the efficacy is something which they want to observe, and this would be crucial for Indian population, because then the use tends to be improved in terms of a country which is very large. When you look at Bharat Biotech, that is a inactivated virus which we described earlier. We still do not know the efficacy at this point in time, but this is a whole virus. And we look at Sinovac, which is a Chinese vaccine. This is also inactivated whole virus vaccine. Now, here, if you look at the efficacy that has been reported, it comes into ranges, mainly because different countries are reporting different figures as such. The initial claim was about 91% efficacy, and now recently Brazil has also said that perhaps the efficacy could be as low as 50%. And there is a small issue that we need to understand. Even Brazil is asking for a vaccine from Bharat Biotech. So essentially, no, it appears that these vaccines either have similar kinds of efficacy. We do not know whether we should believe about that 50% efficacy figure being as lower. One of the reasons being, these countries where the clinical trials conduct or vaccine trials conduct may not be as strong as you would see in the developed countries, may also be impacting figures. And the second thing, which I will try to come maybe at a later stage, perhaps will explain certain other issues as well. Given the urgency of this vaccine, WHO said that vaccine with more than 50% efficacy will still be acceptable. Now that it is so high, we don't see an issue why efficacy should be a major botheration in terms of providing vaccines to people. The implications of reported high efficacy by most of the vaccines tend to suggest a couple of things. Spike proteins appear to be the best immunogen, and most of the vaccines have spike protein as its own main component, or as in the whole inactivated vaccines, you have entire virus which also includes spike protein. That's something which we have to keep at the back of mind. How is a vaccine developed? We know the vaccine is developed in lab setting, then it undergoes preclinical toxicity among animals. Then you have phase 1, phase 2, phase 3, and phase 4. In phase 2, until phase 2, you require smaller number of people to participate in those studies. But when it comes to phase 3, where you test for efficacy and side effects, you require large number of people. It could run into 1,000, 30,000, 40,000 people, depending on sample size calculation. And then, even if I follow up people up to 1.5 years in a standard pattern, you will find you will still need to continue to do phase 4, that is post-marketing surveillance, just to find out whether there are certain side effects which have gone unnoticed because the number of recipients of those vaccines may have been small enough. The impact is, though this technological development advancement has led to large number of candidates, we know that the duration of vaccine development program of 10 to 15 years is compressed. Vaccine trials have also become shorter in accelerated approval stages, and therefore it leads to certain issues that we need to understand. One is the it becomes very easy to undertake a trial when the outbreak is extremely severe and it is exploding. You will find that the calculated number of infections that you require for interim analysis perhaps can happen very quickly since the outbreak is severe. And the second thing which we also need to understand, that since these are being calculated at the time of interim analysis and efficacy is being decided based on interim analysis, there will be a marginal decline in efficacy over a period of time. Like for Pfizer, initially when they calculated it based on 7 days after second dose. Now, if the person is exposed only for 7 days, that impact is going to be different than a person who is exposed to a sustained outbreak that occurs over a period of time which could run into years. So there may be a marginal decline which we should expect in terms of efficacy, but we will not know about it. That's another thing which is going to be a major challenge, because ethically now we will be required to provide a vaccine to the control group. So essentially that data, how it is going to emerge is a big question mark at this juncture, and it also impacts assessment of adverse events. Now, which side effects can occur due to vaccination and how common are they? The serious side effects are, as we know, the anaphylaxis, which is very rare. Most of us know about it. Rarely you could have transverse myelitis and encephalopathy. And also rarely you might find that there are certain individuals who will develop auto antibodies. And that's something which we may have to worry about. But generally, these side effects are detected very early, and that happens within 3 to 4 months of follow-up itself. So early and immediate toxicities are generally known when the participants have completed the follow-up of about 2 to 3 months time. But long-term adverse events could still occur. They may be related to re-exposure. They may be missed even in a normal trial. So you have to make a calculated guess as to how much should I wait in order to know about every side effect at this juncture. Temporary local and systemic side effects are seen with AstraZeneca vaccine. 60% of the trial participants tend to develop tenderness at the injection site. Headache could also be occurring in more than 50%. People could develop fatigue in more than 50% instances. Muscle ache and pyrexia are fairly common, along with chills, joint pains, and nausea. Now, the reason why they are being mentioned is the person who's taking vaccine should be aware of this, because it is possible that that could impact his subsequent behavior, whether to take the vaccine or not, the second dose. According to Bharat Biotech, only about 7% of the participants had these kinds of side effects in phase 2 trials. It is important that all those who take these vaccines need to remember that they are expected to take 2 doses of vaccine. Occurrence of side effects, the ones that we described earlier, should not have some implication for taking second dose. The second dose has to be taken after 28 days. And generally, the side effects tend to become lesser after the second dose compared to the side effects that you see in the first dose. Are these adverse events going to be monitored? Yes. They will be under medical observation for 30 minutes after vaccination. We have a robust AEFI system where reviews will be done, and they have been done for childhood immunization. And PVPI will be looking for abnormal signals that they may pick up from adverse events that tend to occur. So we would be in a position to know if there is unusual kind of adverse event that is seen as such, which could be very rare. How's that we could develop vaccine in last 11 months? Now, that's one reason why people tend to have vaccine hesitancy. We need to remember HIV was one of the first major challenges. So people started looking at developing vaccines in 1990s against HIV. they failed. But in the process, they developed different vaccine platforms for development of vaccines against HIV. They could try some of them against Ebola to a reasonable success as such, and one vaccine could at least emerge very strongly. Now, what they did was these platforms were kept alive for any emerging or re-emerging infection, and within 2 weeks of reporting of this infection and the genomic sequences, you find that the scientists in USA, UK, and China started working for vaccine development. And that's the reason why vaccine development could occur very fast. Should one take only one dose? Definitely not. And the reason why people think about it is if you look at Pfizer's data, it shows that after 12 to 13 days, the vaccine protection tends to start. But do we need a second dose? Yes, we need a second dose. The reason is with the second dose, you not only increase the avidity and affinity of this vaccine, you find you would have a robust response, immune response that tends to be retained there. Perhaps the durability of protection also depends on the second dose that is being provided to people. If I am admitted in a hospital at present, how do I get the vaccine? You should not immediately take the vaccine if it is a serious sickness. And the doctor has to evaluate the immune status because you need a robust immune system to ensure that you will have an adequate protection that will follow after provision of vaccine. And therefore, one if there is affection of immune status, which includes even COVID, occurrence of COVID, the patient is in the hospital or recently he had COVID infection, then he can take 4 to 12 weeks time after illness to ensure that the immune status responds in a positive manner. If I am receiving monoclonals for my disease, can I provide this vaccine? Absolutely. There is nothing to worry. These are not live vaccines. Should we be providing vaccines to those who were infected by COVID earlier? No, we need to provide. The reason is we don't know how long the protection from natural infection may last. The most recent report that has come out of a study, it tends to suggest that it could last for almost about 8 months time. It is it is possible that it may not last for a more longer period. We don't know. So we have to assume that it may not last rather than last and remain in a complacent phase. The vaccine may work as a booster for immune system. Rarely it may cause severe disease in presence of antibodies. But we must remember that this is only because of the dengue experience or RSV experience that people tended to have. But then we have to remember that so far 2.85 crore people across the world have received the vaccines as such. Most of these places, they continue to have serious outbreak of COVID-19, but we haven't got any kind of data to suggest that it could happen. Please take 2 dosages, even if you had COVID infection in the past. And this is very important for healthcare workers and frontline workers who were at high risk of acquiring this infection. And therefore, they will also be thinking in their mind, since they had COVID, should I avoid taking this vaccine? Any group, is there any group where caution is required during administration of COVID vaccine? You have lack of data for pregnant women and children. One would rather prefer not to start doing things with pregnant women and children at this point in time. We can still afford to go ahead and immunize others as priority population. Perhaps that would be a more prudent step as the evidences tend to suggest. Though in abnormal circumstances, if a pregnant woman is facing a severe exposure, in those circumstances, one could still try. And most often, you might find that it doesn't cause any problem. The reason is if it's a pregnant woman close to delivery, you don't expect any teratogenic event to occur at that juncture. If a woman is lactating, do I need to stop lactation? Perhaps not. One must remember COVID appropriate behavior, observance of the same is good enough, and the data tends to still suggest that it doesn't increase the risk of acquiring infection to a neonate. History of severe allergies, no, we need to wait here. No, let the doctor decide on case-to-case basis. Though many patients would have allergies as such, Not every allergy is going to cause anaphylactic shock or anaphylactoid reaction also. Now, that's something we should be left to the doctor. Perhaps the prudent policy will be you could provide the vaccine and ask the person to wait for a longer time after administration of vaccine. What if somebody is immunocompromised? There is no problem with the current vaccines that will be available in India. It is possible that these people may not respond or the take of the vaccine may be lesser than an immunocompetent host. However, every effort should be provided to vaccinate them because this is a risk group which perhaps can lead to emergence of mutants as such. Will these vaccines require a booster or how long will the protection last? There is only a historical evidence which we can definitely point out to. SARS is one of those diseases that is also closer brother of this particular infection. In a cohort, serial IgG titers were done for 6 years among these 23 or 22 odd patients because it didn't happen in magnitude as heavily as SARS-CoV-2 is happening at this juncture. It's very clear that if you look at this data, the antibody titers tend to dip down. Now, these antibody titers also dip down for other infections as well as vaccines also. But one must remember that when we get a positive report, let's say for measles antibody, it tends to reflect to us that the diagnostic test requires far lower antibody titer to diagnose whether somebody has antibodies or not. Now that refinement is yet to come in SARS-CoV-2. Perhaps second or third generation of test would be able to distinguish in a little better manner. But if you look at that particular cohort, you find in this cohort also the memory T cell responses tended to last right up to 6 years, which is an important facet that we have to remember, that with the infection, the memory T cell response is also likely to be good. And in this connection, the only thing that we need to remember that it also tells you, in other words, one anxiety, whether I'll have to take this vaccine every year or would it be something like an influenza vaccine. Perhaps there is no reason to worry at this juncture at least, though this will be a purely speculative statement. To my mind, you would require more than 1 year's time or more than 2 years' time, if at all, if we require a booster to be provided to people. There are two misconceptions that you commonly see in social media. Does it cause sterility? It's incorrect. I don't need to tell to the doctors group. Has components from pork? One must remember at least the vaccines that are being approved in India don't have it. And other approved mRNA vaccines across also don't have. They have already come out with that statement saying that we don't have this kind of a compound. Now, will one receive different vaccines as two different dosages? That is not going to be done in India, and that's a good thing to happen because we need to remember that the company has generated data of protective efficacy and adverse events based on two dosages of these vaccines. Unless you do interchangeability design, we can't be sure of both of them. Fortunately, we are in a better position, mainly because we are the largest vaccine manufacturers in the world. The government is able to ensure that a large dose would be procured only from our own people, manufacturers. So we are not going to use this in India at this juncture. When will others get the vaccine? After the first priority group, no, probably it might end sometime in September 2021. The process will be developed to include including the decision to provide free as to how we will go. And why is this being done? Because the outbreak is dynamic. It will continue to occur. So the way we would analyze the need would differ at the time point when we are likely to complete our first priority group. If I want to defer vaccine taking, can I do it? Of course you can. It is a purely voluntary, it is given on the voluntary basis itself. It is not yet clear, but there are certain cautions that we must remember. It is not yet clear whether one can defer taking vaccine and then say, I would like to receive it after 3 to 4 months time because it poses huge operational challenges. Perhaps one may have to wait then if you decide to defer until the time the vaccines are marketed in the private sector. Now, one issue that we need to remember, that if the biggest fear that the government has is, if you give the permission to market, would it lead to development of fake vaccines, and how would we control that, is a issue that we need to think about before deciding deferring vaccine at this juncture. Now, one of the things that we will have to remember, some of us might say, oh, I'm little older, I would stay only at home and follow the COVID appropriate behavior rigorously. Then one has to also remember that this is a droplet infection, and droplet infection doesn't necessarily spread so easily, can be so easily prevented. One must always keep at the back of mind, you could continue to be at risk by people who would be going out to work or wherever, out of the family, and they could be coming back and you would be wearing mask and following COVID appropriate behavior alone. But droplets could be one reason you could acquire it, and the same could happen with the children where you don't need any data to prove it. Vaccines or continued vulnerability, this being a purely voluntary vaccine, as medical practitioners, we need to think about it little more. We are the best when it comes to risk benefit analysis, whether it is antibiotic choice, whether it is a choice between two differential diagnoses, whether it is taking some amount of risk. And we do it every day for oneself and for others as patients. The choice of vaccine or continued vulnerability continues to remain yours own, but we need to think over it before we firm up our decision. Thank you. I'm sorry it was a little longer. I'm sorry. I didn't realize this much.
Thank you very much, sir. Nothing to sorry about. Actually, it was a very interesting and important talk. Almost around 1,500 participants have joined through YouTube, and many of them are non-doctors also. They are watching you interestingly. I think before we put across some questions to Dr. Gangakhedkar, one more speaker was supposed to join, but Dr. Ashish Bharati, PMC Health Officer in charge, but he could not join. Instead of him, Dr. Amit Shah, instead of Dr. Bharati. So I would request Dr. Amit Shah to put across. Dr. Amit Shah is in charge of Medical Officer Immunization, Pune Municipal Corporation, and is also looking after some part of contributory health scheme. He is MBBS DPH postgraduate diploma in hospital and health management. There are many questions for you thereafter for Dr. Amit Shah. Dr. Amit Shah, are you there?
Yes, sir.
So you can just tell us what is the preparedness across Pune section. I think you can mention about the preparedness across the Pune Municipal Corporation in as brief as possible.
Hello.
Over to you, Dr. Amit Shah.
Good evening, everyone. Preparedness for COVID vaccination in Pune is, first of all, it is going to be launched in 4 phases. First is for healthcare workers, then is for frontline workers like police and sweepers, etc. Then for above 50 and comorbid persons, and then general public. For registration for first phase 1 was going for last 2-3 months. For that, you have to register from link given on HMI's portal. Near about 56,000 healthcare workers have registered in that portal. Now from 16th, we are going to start vaccination for COVID vaccine. It is from serum only, Covishield. A nice presentation given by Gangakhedkar sir. So for Covishield, uh, we are having 8 sites right now defined. 4 government and 4 private. Government sites are first Suttar Hospital, then Rajiv Gandhi Hospital at Eroda, then Kamla Nehru Hospital, Sassoon Hospital, and private hospitals are Dinanath, Ruby, Nobel, and Bharati. Bharati already has conducted trials for Covishield vaccine. Now on Saturday, we are going to vaccinate only 800 people at 100 people, 100% at one site. Like that, 800 persons will be vaccinated on that day. It will be first day for new vaccine, and it will be the launch day. Therefore, only 800 persons will be vaccinated. And thereafter, after Monday or Tuesday, we'll be going to increasing the number of sites and number of sessions depending on response and permissibility of software and guidelines. We will be able to complete first dose for near about 24,000 people in next week or 10 days. So, and we are right now we have all this in the hospital setup. Therefore, we are ready for any AFI if at all it occurs. Uh, Over to you. If any questions are there, then I am ready to answer.
Okay, Dr. Amit Shah, some healthcare workers still have not registered themselves. Is there any chance that they can register themselves for the vaccine?
First of all, Pendulkar sir also knows, and everyone knows, from IMA and all the branches. We had I personally had repeatedly requested for registration. Now they had closed yesterday night the link. Still, I will see if link opens. Then I will intimate Dr. Penurkar. Also, other heads like Patil sir from IMA and everyone. If even if you are not enrolled just now, then also you can enroll at the, if your age is above 50, then within 10-15 days or from 16th also, the Prime Minister may launch the phase 3 registration. You can register at that phase 3 also for common public and all that also.
How do you check whether you are registered or not? Is there anything available?
Basically, you can ask your ward office where you are registered. We had registered through ward offices, decentralized way, and we had given the names of each ward medical officer. You just can contact him after 16th, 17th. After the launch is over, the hecticness is a little bit over, then you can check with him. You can ask them by phone or WhatsApp them. They will see and reply you.
Okay.
Okay.
Yeah. And here
See,
there will be no
because
cost restriction.
somebody had come to the clinic and they have taken the data, but whether it has been submitted or not, we don't know. We don't have any proof about that.
Clinic is there, sir?
No, I'm not asking about myself. I'm asking for a generalized public that most of the people have submitted it, but we don't know whether it has been submitted on the site or not. So is there any option how to check that? That is my question. I'm not asking about myself. It is for everyone.
For that, I have
or you have to ask the ward office only.
Right now, you have to ask ward officer, ward offices. They have submitted template, but still the app is also mobile app is going to be launched today or tomorrow.
Okay.
And the launch of apps and all that is and software is being updated. After 16th, when Prime Minister starts the nationwide vaccination campaign, then there will be more clarity on the software
Okay.
and how
Okay.
that will be done.
That's fine.
Okay.
If
Okay.
Okay, I would request Dr. Amit Shah to be there online if he has time. There are some questions to Dr. Gangakhedkar. Dr. S.V. Kulkarni from Navi Mumbai, he has asked one pertinent question. Rather than targeting the seniors, why not protect the young or mid-aged who manage the economy? I think few countries are doing that. Gangakhedkar, sir.
Yeah, I don't think anywhere people are using this vaccine only in the young population as a prioritized population. Because eventually, like our Prime Minister says, Jaan hai to jahan hai. If people survive, the
Yeah. Right, sir. Dr. Penurkar, you want to take the next question?
Yes, Dr. Pradeep D'Costa wants to ask if the range of vaccine storage is REM of the vaccine storage is compromised during the transport or vaccination program. How will it affect the efficacy,
hey,
specifically regarding the temperature?
I think part of that should be answered by Dr. Amit Shah. Now, there are temperature loggers which are there. So you could actually see which vaccine can be used, whether the storage has been proper or transport has been proper. And that is done for even childhood immunizations. So I think that issue is tackled well. I'm sure PMC must have done the same. He would be in a better position to tell.
Right. And Dr. Deepak Falgune wants to ask, second dose exactly after 28 days of first dose may not be possible for some. So, what is the range in days for second dose after the first dose?
See, nobody has defined range. Yeah, if you go by UK's data, they have arbitrarily assumed, I would still say very firmly, that the range could extend right up to 3 months period. 4 weeks to 3 months.
I think sir has dropped out. Mm,
I would request Kakrani sir.
No, I think he got disconnected. Meanwhile, I'll request Mr. Mehta to talk for a minute about PPCR. What is this concept that he is running? He is coordinating with COVID management, health professionals, and the industry. And he has done a great job when actually it was coming to COVID management. So I think he'll just talk in a minute till we get connected to Dr. Gangakhedkar.
Yes. Good evening. I think, first of all, let me start by saying that it was an excellent discussion. Many of the points which I'm sure all of you are looking at have been covered. To give you a short introduction on PPCR, we are a volunteer group that got formed in March of last year. And we are a group that comprises of industry, government, doctors, epidemiologists, as well as all of the sections who have been working on the COVID pandemic, including many NGOs. We've been working across the Pune city for almost the last 1 year now. And I think collectively we have been able to work to see that Pune, which was the worst and the most affected city initially, has now got the pandemic under control. I just want to make three quick points which are non-medical. One is the COVID pandemic by no means is over in India. We have controlled it very well, much to the credit of all of the doctors who are present here today. I think the medical community has done an absolutely fantastic job, and we are deeply grateful for them for doing so. Number two, this has been a collective effort of both the public sector, of both the government hospitals as well as the private hospitals. And I think this will also be the nature of the vaccination campaign for the country of the size and scale of India. It's not possible for the government to do it. We are very happy to see that even in the first phase, the private hospitals have been involved in this. And just to give you a perspective for Pune, almost 70 to 75% of the COVID patients so far have been treated by private hospitals. So I think a campaign of this size and magnitude will involve almost all private hospitals to be involved in one way or another over a period of time. And I'm sure they will step forward to do that. The one very important point that I want to make is India has actually done well, relatively well in this, because we've all been together. And I think as far as the vaccination campaign is there, it's very, very important that we rely on science. Number two, most of you are doctors on this call today. I think you will set the tone for what the country thinks and what the country is talking about. One of the challenges of such a large campaign is that there is a lot of information and misinformation that goes around. I think it will be very important in the coming days that we all talk with facts, we talk with data. We don't jump to conclusions. Wherever this vaccine campaign of this size has started, there have been initial challenges. There also has been a lot of misinformation. So it's extremely, extremely important that we rely on the experts and we rely on the information to take our decisions. Whether to take the vaccine or not is an absolutely personal decision, but at the same time, it's very important that the correct communication and the information is done. Lastly, I want to say that I think India has the capacity to do this. Less than 24 hours after the first movement of vaccines, more than 1 crore vaccines have been dispatched to various parts of the country, which by itself is a huge feat. I think the next challenge will be to see that once the vaccination campaign starts, it picks up speed very fast, and I'm sure we will be able to do that. And collectively, we will be able to see that the worst of the COVID pandemic is behind us and that we are able to control it. Thank you.
Thank you, Mr. Mehta. I think Dr. Gangakhedkar has joined. Dr. Gangakhedkar, it gave me a scare. It gave me a scare when you told that the India's first wave is coming to an end. So you, so without vaccine, you feel we will also follow the pattern of US and UK?
Of course, yes. No, one has to understand. No, sir, थोडंसं मराठीतही बोलतो कारण ते आपलेच लोक आहेत सगळे. मी very recently I had to travel to Aurangabad for some reason, because somebody had passed away. Now, when I started moving, I realized you leave Pune. Pune has at least some use of masks. But you move towards Ahmednagar from far, let's say 100 kilometers after Ahmednagar, before Ahmednagar, the whole thing until Aurangabad appeared as if there is no coronavirus. Now, which essentially means what we tend to speak tend to be reflection of our own experiences, and we tend to believe that since I am following COVID appropriate behavior, now this will not come. But to my mind, not only the COVID fatigue, but also the newer variants that will come will perhaps pose a major challenge. There is no reason to remain optimistic. We cannot develop complacence. We have to believe in continuation of COVID appropriate behavior. This is not only for those who are not vaccinated now, but it is also for those who may be vaccinated. They will have to continue to follow COVID appropriate behavior. Perhaps these COVID appropriate behaviors are going to stay here for next 2 to 3 years. As I assume, if something dramatic tends to happen, I stand to be corrected. As a person from data science, no, I would believe anything that happens when it actually happens.
Dr. Asmit Vaidya is there online. Dr. Asmit Vaidya, you want to ask?
Yes. So very good evening. Am I audible?
Yes, you are audible. Please go ahead.
What should be the antibody titers be to deem a person protected against this COVID virus?
Yeah, that's a little tough and tricky question. No, you are talking of correlates of protection. No, we call it in our scientific this
Okay.
thing, we say correlates of protection. Now, correlates of protection, the only paper that is currently available is from animal studies. I didn't want to make a very technical presentation. So I didn't show you. Maybe some other time I will show. No, they have used certain antibody titers in animal studies which were immunized against it, and they found that anti-RBD ELISA, where the titer was more than 137, perhaps is a reflection that there is some correlate of protection of significance that has taken place. No, perhaps the animal is protected. But can we transfer this data directly into human beings? We still don't have that idea. There are scientific groups which are working on correlates of protection, but do we think it would be very easy to do it? Perhaps not. No, the two reasons is no, reinfections they continue to remain uh, a rare event. So we do not know what could be a protection level in a situation where the outbreak will start declining. When the outbreaks decline, you will find it far more difficult to prove correlates of protection. But we will have to wait.
Thank you.
So one very important question which has come from the YouTube audience, which I want to highlight here, Ms. Dr. Jayan Pandharikar asks that you, of course, mentioned that a person who has suffered from COVID should take the vaccine. Specifically for those patients who have gone through the cytokine storm and come out through a very turbulent and stormy course, recovered from that. Uh, is there any data which says that it is okay for them to take the vaccine, or should they take the vaccine?
See, that dilemma will continue to be there until a stronger evidence emerges. But
Yes, sir.
having cytokine storm is likely to be a condition which even for me to give you a straight answer, I would not be in a position to provide that, because cytokine storm is also a reflection of immune system acting against spike protein, no?
Yeah.
Or the antigens that have entered. Now, when cytokine storm was experienced, I have no clue whether a small dose, because that may be dependent on viral load and the genetic factors which that individual has, because it's clearly shown to be related to interleukin related genes. As of now, there could be multiple genes. But then we have no idea whether one would be completely safe. But I suppose that data will also emerge. I would not like to boast or speculate on lack of data in this particular area. I would prefer to say sorry that I don't know.
Yes, sir. Thank you, sir.
I think Dr. D.B. Kadam sir is also there. He's the member of COVID task force, rest of Maharashtra. Dr. Kadam sir, you want to comment? You want Pushkar Kadam sir is there?
Yes, he's there. Uh,
सरांचा आवाज खूप दिवसांनी ऐकणार आहे.
uh,
कदम सरांची बोललोच नाहीये.
Kadam sir, could you unmute yourself? Yes.
No, the thing is that, as Sir has said, we don't know things to clarity still, and most of them are speculations. One of the speculations which was put forth, that anybody who has COVID, he should avoid vaccination for 90 days, same as anybody who has received convalescent plasma or monoclonal antibodies. So the antibody levels might be there in the patient's circulation, and that might lead to reduced protection after giving vaccination. So this opinion was expressed when we had a meeting with Indian Infectious Disease Society, that if the patient had acute COVID, then 90 days post, or if the patient had convalescent plasma or the patient had monoclonal antibody, They should avoid it for 90 days and then they can get the vaccine. Those who will get cytokine storm are likely to get better immunity, and those who are asymptomatic carriers are likely to have less immunity. That was the second proposition which was talked about over there. So whole thing depends upon, because there is nothing clear, as sir said, ki what is the IgG level which would be protective is yet to be ascertained. Like
Hey, I agree completely. Sir, त्या CDC guidelines आहेत. 90 days वाले जे आहेत ना, those are CDC guidelines that have been given. But even for that, there is not so robust evidence to suggest that. But these
yeah,
are done on a little sound theoretical principles. With
yeah,
respect to cytokine storm, I would not like to speculate solely because it has also got a genetic component attached to
yes.
it. And therefore, I would not know whether we provide vaccine and then something would happen. I would not like to take that risk.
Yeah, and secondly, in cytokine storm, there is a lot of use of steroids, and whether steroids themselves will reduce formation of B cell mediated antibody production. That's again a question to be answered yet.
Absolutely.
Kadam sir, there are many non-doctors who are listening to us. They are eagerly waiting for the vaccination. When do you think the general population, apart from the healthcare workers and the frontline workers, would be able to get the vaccination?
As Dr. Amit Shah said, so the priority list which we have decided is first health worker, then the police and other people who are facing the public, and then the elderlies, and then the general population. So how many centers would be there? What would be the extent of vaccination? Do like Israel, they have attended large population in very small time frame. So we have to just watch and see how would be the further proceedings regarding vaccination, and the whole thing depends upon, in my opinion, is the press and what type of publicity this vaccination gets. Even a single adverse event we have seen in past has killed vaccination drive in other vaccines. So that part is also to be kept in mind.
One practical question which comes from the common people is that there were news that probably in the future there is going to be a need for some vaccination certificate if there is to be an international travel. So of course, there were positives and negatives about this, but with respect to logistics about giving vaccination and during the drive, would the uh, persons who would be getting the vaccine be getting some authentic certificate of being vaccinated so that they can use it if needed for international travel?
Yes, they are going to get. I think Dr. Kadam can add, or Dr. Amit Shah can tell the exact details.
No,
Actually,
just
they may see the antibodies as they see in when they admit students in American universities, that they see titers and then they only give the admissions to them. Maybe I think they may ask to produce antibody titers before they permit them without quarantine. Not sure,
They,
but this
they,
is what is they do in when they admit students in American universities.
but it is quite likely that they would ask for a vaccination certificate because these are bilateral um, relations related issues. There are many countries which tend to dominate that field. The scare is extremely high. Therefore, they are vaccinating their population. They would not like to see that somebody walks in and comes with a viral strain which could ignite another outbreak at that juncture. So it is possibility that cannot be ruled out. But government has taken care of it. That app will ensure that certificates will also be issued.
Yes.
One question
I
from
think, I
the
think, I think there is so much transparency about all these things. So certificate will definitely be handed over to the patient, at
No,
least on
they
the
have
app.
already announced. They have already announced.
Yeah,
Will
there is a
issue
lot
it.
of transparency. So I think things should be that way. Very well done.
uh, Dr. Bande has one observation that it was clear that underdeveloped world seemed to be less affected in this pandemic. Any scientific explanation for this thing, Dr. Gangakhedkar?
There is one thing which we have to remember. Uh, what we see may not be a true reality, because it all depends on how much of flooding of tests occurred in that country. No? So one cannot just go by numbers as they appear, whether it is in JHU, COVID tracker, or any worldometer or whatever data that you see, because it's a function of, and the less developed a country, the less expenditure it is going to make even on detection. So those are issues where we shouldn't draw more conclusions than necessary. That's one of the reasons why I always used to feel that perhaps there has to be some kind of score which tells you the number of people who are hospitalized, and a ratio could be drawn between them to tell you. But that kind of cohort data has not come up because of age compositions being different.
Excuse me, it is a multi-dose vaccine, right? Multi-dose vial, which is coming. So what should be the dose for each 1 ml or 2 ml?
Uh, अमित शाह असतील ना सर, त्यांनाही बोलायला.
I think it's a 5 ml
So,
That
vial.
no, dose is
10
0.5
doses,
ml. Dose is
sorry?
0.5 ml.
10
Okay.
doses in one vial.
Yeah,
It is 10 dose
10
vial.
dose in
It
one
is
vial.
10 dose vial.
Once it
Yeah.
is opened, it has to be finished within 6
4
hours.
hours. 4
4
hours.
hours.
4.
4 hours.
4 hours.
Dr. Gangakhedkar, one question which was quite relevant till a month back, not now relevant, that certain other vaccines increase your immunity. People have taken RBCG or conventional BCG and MMR. Now nobody may be asking this question, at least maybe some common people will ask, well, till that time we get, should we go for those vaccines? What is your answer to this?
Sir, those were all association studies. No, they were cross-sectional studies where attribution to a particular intervention like BCG tends to remain weaker until you actually show it in a cohort longitudinal study. The efforts to build the cohort started, but as you must understand that no, they take their own long time. It's like doing a vaccine trial by themselves. No, so those results were given, those efforts to actually vaccinate were given lesser priority at a time when vaccine trials were ongoing. So you will get the data, but you will require a longer time to have actual data to say whether it protects or not. No, but until then, I would say it is a speculation. Now that we know that some good thing can happen with use of vaccine, if BCG is also protective, perhaps it's augmenting one's own protection to a larger degree using both the interventions. You may not necessarily take BCG, or you may additionally take BCG. But I would be cautious in making statement whether it is protective in absence of longitudinal data.
Right, sir. And one question pertinent to your both fields, HIV and COVID. What about the false positive HIV seroconversion post-vaccination?
False positive seroconversion of HIV? No, it doesn't
HIV.
occur, sir. No,
So what they reported in Australia, for a particular, I don't know, there was some reason they reported this in Australia. There was one report.
No, no. At that time, when we were faced with the challenge of doing validation studies for all the kits that were being brought. No, the panel that we have used, no, by and large, we had malaria, we had dengue, we had no, the common diseases, including HIV, as a part of it, and we essentially saw that cross reactivities also were not occurring as often. So we don't have any data to say in India that there could be cross reactivity.
Right. Uh, Dr. Amit Habbu wants to ask, there are some probability models which suggest that random vaccination may help reduce transmission rate faster, not in the groups. Has this been studied and rejected by ICMR?
आता मॉडेलिंग काय असतं सर मॉडेलिंग मध्ये no, you tend to use all kinds of assumptions, no, and if you tweak with the assumptions, your outputs are going to be different. Now if you say they should be provided randomly, now that's very difficult to be even operationalized for us. Now if there is no purpose but only to raise herd immunity, it will become difficult for justification of a, I won't call national program, but a public health emergency. No, in public health emergency, for whatever you are going to use an intervention, you need to prioritize even the objectives for the same. And the prioritized objective is reduction of mortality, because that's very important, because those who may not fall in that vulnerable group, the likelihood of death is also going to be low. Now, if you think how people's lives will be saved, it has to be the healthcare workers and frontline workers. Now, if I move beyond and say that I would like to play with reduction in transmission, now it would then assume that you have sufficient stocks to play with that kind of issue, because then you will have to vaccinate a much larger population for deriving a benefit, because this benefit requires a small number of people compared to what you would do with random vaccination.
We are going to have different kinds of vaccine over a period of time. As of now, there may be only one. So, is someone going to get a chance to choose between the vaccines? And one candid question to you: if all the vaccines were available, which vaccine you would have chosen?
I can't answer that for one simple reason. If I do anything, no, one, the reality is I don't have choice of vaccines. That's number one. Now you look at the backdrop. If I say that you use, I would prioritize X vaccine, somebody would just say, अरे इसको पैसा दिया है वैक्सीन मैन्युफैक्चरर ने जब जैसा चॉइस करने का अगर मौका रहता था तो चॉइस कर सकते थे. अभी तो देयर इज हार्डली एनी चॉइस टू.
I think Mukund Pendurkar sir is trying to ask a coffee with current type of a question here.
Huh?
But one thing is certain, that if I ask you tomorrow on 16th, first day only, you, because this will give message to all the healthcare workers who are seeing this program today.
सर मैं रजिस्टर्ड भी हूँ क्या मालूम नहीं. मेरा ऊपर से क्या है, मुझे एंजियोन्यूराटिक एडिमा 2 बार हो चुका है जिंदगी में. एक 5 साल का था जब वो टिटेनस का दिया था, क्या एटीएस दिया था वो मालूम नहीं, और उसके बाद में एक बार मैं कुछ तो ये करते हो. आई हैव नो आइडिया, बट आई डोंट नो वेदर आई एम रजिस्टर्ड हियर और एम आई काउंटेड इन दिल्ली. It starts with that.
No, supposing this issue was angioneurotic edema was not there, and you were registered in Pune,
100%.
will you take?
I would have gone.
So that gives message to everybody that who is attending this program, that we should take it. You had in the your last slide said the choice is yours.
Choice is yours. Moreover, selection of the place, because I looked at the when he told, and I think in one of the groups the sites came. The only thing that I was thinking, if I have to go, I would go to a place where they have good skills to attend for an emergency if ever it arises. That's all. And then I was planning, I wouldn't, like as I said, I wouldn't talk of even the hospital, because that's then likely to say कि वो उसको favor कर रहा है.
Pushkar, are there any questions from the YouTube live chat?
Yes, one very practical question, which of course Sir has covered almost all of them which were asked. So I think one question which was just commonly placed, one interestingly came from a Bangalore animal liberation organization, and they ask whether how are these vaccines created? Are they use fetal bovine serum? Uh, is there I mean there would be some groups which would be vegetarians and vegans, so how do they respond to this? And as you rightly said, this all comes out of that vaccine hesitancy more than eagerness. So this was one of the common question asked, like the base whether there is kind of any animal material here. You mentioned about pork, but about the others is something that they want to ask.
See, there is only one thing which I would say. We when we live, we tend to live with a convenience bias.
Yes.
Now, we by and large decide something and then find something to defend. No,
Yeah.
there are different things that we do where we know for sure, no, that there could be a material which you or your religion does not allow you to do it, but we neglect it. But we neglect it because we think what we are doing is what is required for that situation. So I would believe that we should not dissect it to such a level from where everything is happening. Perhaps it would not be a very prudent policy to look at from where this fetal bovine material came. Would it contain fetal bovine material as such? Perhaps I would suggest to him that we shouldn't dissect too many things, but it is up to him to decide. These are my own views. They don't mean anything to anybody outside
Right,
and
sir.
should not.
Right, sir. Thank you very much. I think most of the questions on YouTube have been covered by sir already. So if Dr.
Is Rishikesh Joshi there? If I think he was also coordinating to take questions from YouTube. Ashwini,
Yes, yes, I'm there. I'm there. There was one more question about the vaccines. If the pregnant doctor should take vaccines.
Pregnant doctors, I would encourage not if in the first trimesters of this thing, especially when organogenesis is occurring. There is another thing that they need to remember, that in any case, there is an additional protection of use of PPEs that doctors have. So for tiding over the temporary period, perhaps they may refrain from taking it. But if they have to take it, they may take it a little later, because we still don't know anything about teratogenicity, but it is unlikely to come. But as I said, these are speculations, no hard data.
Right, sir.
Kadam sir, any closing remarks? DB Kadam sir.
And now I think we must close, because my grandson is coming and he is all the time saying, "Wow, it's 1.5 hours." He's tired of seeing me on the VC for such a long period of time.
Kakrani sir?
I think we should stop it. We, of course, now I am seeing him often on TV channels last 2 weeks. So I think we can meet him there again once in a while.
Right.
Yeah, I think the call has come.
The
call has come. I think we can call it a day now.
Yes, I think
Yes.
it was a fantastic session. And for the statistics, the people who viewed apart from this Zoom meeting were around 1,400 people, probably across India, who viewed. Of course, this they were eager to listen based on what topics we had posted. So thank you very much, Dr. Gangakhedkar sir, Dr. Kakrani sir, Dr. DB Kadam sir, and over to Dr. Pedurkar sir for the closing remark.
Thank you very much, Gangakhedkar sir. It was a very nice talk, and it was really a candid one. We could interact with each and every question, whatever was answered, whatever was asked to him. And thank you very much, Dr. Amit Shah, for coming in, joining in at the 11th hour because of not availability of Dr. Bharati. And thank you very much, Kakrani sir and Kadam sir, for being there always for such important talks. And we are very much thankful to the audience because I think it was circulated today itself to all the audience of our YouTube live streaming, and almost 1,500 have joined in, and I think they must have enjoyed, or they must have been benefited with this particular topic, because many were asking, or I think each and every day we get four to five phone calls for the same questions of vaccination: when, where, and when will we get, and which vaccines, and whether to take it or not. I think Dr. Gangakhedkar has answered almost each and every question, and now the audience is better educated with whether to take and when to take vaccines or not. So I think we can close the show. Pushkar, Rushikesh, Ashwini, Preeti, if you have any comments, you can just keep in and ask any question or comment yourself.
Yeah, I think Dr. Gangakhedkar sir is it's high time for him also. So I think we can close the session now. We have got fantastic comments from YouTube. They were all of the participants and all the delegates and attendees were very happy. So thank you again for this, and I will end the session now.
Thank you. Thank you for the opportunity.
Thank you very much.
Saran,